So this is the University of Louisville spine neurosurgery team. We're going to present 3 clinical cases on Hangman's fracture. The first case is going to be presented by former spine fellow and now resident, Dr. Mayur Sharma. And then the second case will be presented, the third case will be presented by Dr. Fabian Carballo and Madrigal. And then after that, I will give the talk. I am the chief of spinal neurosurgery here at the University of Louisville. So we'll move into the first case now, and Dr. Mayur Sharma would present the first case as well as the second case.
Thank you. Good morning, everyone. I'm Dr. Sharma, one of the neurosurgery residents at the University of Louisville. I'll be presenting first 2 cases here. The first case is a 38-year-old male chronic alcoholic with a history of deep vein thrombosis on Eliquis. He had a fall from a creek under the influence of alcohol, and it was around 12 feet in height, and possibly under the influence of alcohol with some withdrawal seizures. When he presented to us in the ER, he was neurologically intact. CD head was unremarkable, and CT cervical spine showed Hangman fracture with listhesis of C2 on C3. These are the CT scan images when he presented to us. There was 4 millimeter enterolisthesis of C2 on C3. Focal kyphotic angle was 19 degrees, and there was a local angulation of 17 degrees of C2 on C3. These are some of the parasagittal CT cuts and showing the displacement of C2 bilaterally. And then the middle one is showing a coronal image. There's not much deformity on the coronal slices, but on axial you can see the displacement. However, the fracture was not going into the foramen. Based on this morphology of the fracture, we decided to get MRI also on this guy. MRI, the first one on the left showed a sagittal image with a lot of stir signal on the posterior musculature, as well as there is a disc disruption, and there's a herniation of disc in a sagittal plane upwards. And we see all the PLL looks okay at this image, but in some of the parasagittal cuts, there was disruption. And on axial slice, we can again see how the PLL was pushed, and then there was significant disruption along with disc herniation. So based on these images and the clinical presentation, we classify the fracture as type 2 FND and type 2A Levine and Edwards. So the question came up, like, how we're going to manage this patient, just conservatively or do surgery. Given the severity of fracture, we decided to do posterior surgery in him first. Yes, Dr. Chapman.
Yeah, so thank you. So if you go back to the imaging, before we go to the surgical treatment, again, the basic problem of Hangman's fractures is dramatic name. They look horrible on images sometimes. Like the MRI here shows a lot of stuff like the disc disruption. And the general history of those is, however, very benign. Now, you made a very important distinction that this is a type 2A of the Levine classification, which would change things around a lot. Can you briefly just go over what makes this a 2A and what is so different about a 2A injury compared to the others? Thank you.
Sure. So based on, as mentioned in the chart, type 2A is severe angulation without translation. However, I mean, we gave a lot of importance to the angulation part, as I mentioned on a CT scan, the first image which shows angulation of 17 degrees here. Although as per the translation also, there's 4 millimeter translation. So technically, we can because angulation gets more importance to classify as 2A. That's why we decided to put it in 2A. And there is no disruption of facets. That's why I didn't classify it to be in type 3. Does that answer your question, sir?
Yeah, no, so the point about Dr. Levine's subclassification was that there's a subtype of these otherwise benign looking injuries that basically behaves like a disco ligamentous injury where it's like a flexion distraction injury. So there's an instant moment of rotation somewhere anterior to the vertebral bodies that basically tears the posterior ligaments apart. And if you were to apply traction, for instance, with a halo on this fracture, which you'd not want to do, obviously, you'd get far more kyphosis. So this whole thing would actually translate. So the healing rates of type 2As using very modest data, I don't want to take Maxwell's great talk away yet, is far poorer. They basically kyphose far more readily. The static angles themselves, I'm a little bit leery of, although they can be a helpful hint. They by themselves probably should not dictate treatment. Understanding the injury and that this is like a flexion distraction injury of the C2-3 motion segment is probably more important. That's just my 5 cents.
Okay.
Thank you.
Okay. Thank you. So that's a great point. So based on that, we understood that that this fracture was pretty unstable, and given the translation and angulation, we decided to go with surgery, and we decided to go with the posterior instrumentation first, going from C1 to C3, using intraoperative navigation. And given his history of being likely non-compliant, we decided to use BMP as well. So these are some of the intra-op images using O-arm, which shows appropriate placement of screw. However, when we placed our C2 screw, the reduction was not optimal at this point. And and the displacement also did not reduce a whole lot. I'm going to show you in the next X-ray, which are standing X-rays on post-op day 1. Which still showed some amount of translation. So basically, he was fused at the same morphology what he came with. So based on this post-op X-rays, we offered him front surgery as well because there was significant displacement. Plus, he did not. There was no great reduction after posterior only fusion. However, he went AMA at that point of time. And he came back to us 6 weeks later. We just saw him a couple of days ago with this. And at this point, we are still working him up, planning his surgical correction at this point.
That's a great case. Thank you for sharing that so openly. I think that the decision for surgery was a very good one. I think it's very apropos. It is very difficult to do these patients who have healing impairment right. They will test the limits of your fixation dramatically. And again, here the weak spot was probably C3. I assume that this patient was very malnourished and had poor bone density. So the panelists, some of the chat that we're getting here identifies, again, some of the questions that I'm going to ask. So intraoperative reduction of these Hangman fractures, that's a very difficult subject. How long from his injury was this patient out? How many days from the injury had passed?
Almost 6 weeks. This is his first post-op visit.
No, sorry. When did the surgery take place relative to the injury?
Next day.
Okay. Well, the general thought, what I was leading to was the earlier a reduction takes place, the better. So you did that. Never mind. There's not a really good reduction trick. Sorry. How to get Hangman's fractures back, because you have to rely on ligamentotaxis. You can't really grab the C2 body, as you know. And one of the commentators, I thank him for that, asked, why did we not do a lag screw? Why did you not do a lag screw? That's very hard, but in principle, a lag screw would be preferable in this setting. A lag screw meaning that you overdrill the near cortex and then engage the far bone. But while possible, even with an O-arm, this is something that's kind of a little scary, frankly, because you do sacrifice a lot of near-sided bone. I thought this was a very good fixation. The only thing I would add to that is you had the right inclination to want to support this patient with an anterior cervical fusion and plating. And in very healing impaired patients, putting on a halo with probably 6 pins for the cranial fixation is not unreasonable. That's my Wednesday morning quarterbacking comment.
Thank you, Dr. Chapman. Do you mean halo after posterior fixation?
Yeah, Yeah,
Okay.
absolutely.
Okay.
It just, in my experience, enhances compliance at least for the critical first 6 weeks as you're trying to, and it just gives everybody the thought, especially the patient, that they can't return to business as usual. This is a big deal. I want to just point out that the use of the BMP is obviously off-label. I think it's a good idea,
Right.
but we don't officially endorse that, so this is a treatment choice that the individual physician can and should make. Thank you, though.
Okay. Thank you. I'll move on to second case here. Okay, so next case is a 29-year-old female non-smoker presented to us with a motor vehicle crash with only neck pain. Neurologically, she was intact. Her CT head was unremarkable. And these are the CT scan images showing sagittal as well as parasagittal cuts. The first CT sagittal midline sagittal cut is showing a chip fracture from the inferior vertebral body of C2, and parasagittal cut showing minimal displacement. These are the actual cut showing the fracture line going through the foramen here, and we got an angio on her as well, which showed vertebral artery was intact. There was no dissection in this patient. Then we got MRI as well because of the inferior end plate fracture, and we saw the signal in the sagittal cut showing disruption of the disc. However, the PLL was intact. Based on this, so we classified this fracture as type 1 with no angulation and minimal displacement. Based on this fracture morphology, we gave her option of either conservative management with halo or surgical option. However, she chose surgical management, and we decided to do single level ACDF in this patient, given the low grade of fracture and minimal disruption of the ligaments. She's 5 years out now, and she's doing very well with no issues.
So this is a great example of an anterior surgery that shows the penmanship of a really thoughtful surgeon. The reason why I'm saying that is that the plate was beautifully contoured. This is a difficult surgery, and it can be a very difficult surgery in a larger patient, obviously because of the mandible. You wouldn't happen to have an AP in your PowerPoint, would you?
No, so sorry.
Did this patient have swallowing difficulties afterwards? Dysphagia?
No, she's doing very well at this. I mean, we just followed her 5 years. She's doing well. No issues with that.
So the basic thought here is this is a very nicely done anterior surgery. Dysphagia, swallowing difficulty is the biggest risk. The second biggest risk is that the plate pivots around C3 because of screw fixation. So these are self-drilling, self-tapping screws. So fixation of those may be a little bit suspect sometimes, but they're near bicortical. So the more you're willing to do bicortical screws that are properly drilled and tapped, the better your fixation will be. And getting the C-spine out of kyphosis is a very big deal. So that was very nicely done. Did she get immobilized in a rigid neck collar afterwards?
We gave her collar. We usually give them like this was before my time here with Dr. Boakye, but our standard protocol is to give them collar for at least 6 weeks post-op.
Yeah, that's correct. That's correct. Yeah, she got collar for about 6 weeks.
That's excellent. So beautiful result. Now, the naysayers will say, why not treat this non-surgically? Why not just keep this patient in a rigid neck collar, see how the patient does with a rigid neck collar in place, and get her upright? A halo is a very personal choice for patients. That would have also, by the more conservative-minded people, been a legitimate treatment choice. But I think this is something that I would offer patients, and I think it certainly is preferable over fusing the C1 to C3 joints.
Yeah.
But beautifully done.
Thank you. We move on to third case by Dr. Metrico.
Good morning. I'm Dr. Fabian Carballo Madrigal. I'm the current spine surgery fellow at the University of Louisville with the neurosurgery department. I'm going to present to you our third case of the morning, and this is a patient that we just saw about 1 month ago. And he came into to our office about approximately 2 years after his initial injury and treatment. So let's start. This is a 59-year-old male patient. He's a worker in a tobacco plantation. He's an active smoker. He has a past medical history remarkable for high blood pressure. He had a fall from 10 feet, and that was back in August 2018. He presented at his local hospital with a skull fracture and a C2 fracture, and his neurological condition was intact. This is the initial CT scan on presentation. We can see with the image on the left, the traces of fracture through the pars. On the next image, we can see some translation of the C2 vertebral body on C3. The next image, we can see the fracture through the pars and pedicle. And then the coronal image, we can see the fracture through the right transverse process of C2. So the initial recommendation was a halo, and the patient used it for 2 weeks, but it was removed due to poor patient's tolerance. So the patient opted for surgical treatment. He underwent an occipital C4 posterior spinal fusion and instrumentation. And he did fine for a period of 9 months approximately, but then he started again with neck pain that gradually worsened. These are the first images with the halo on, and we can see actually a pretty good alignment between C2 and C3. But then 12 days later, the patient had a new set of x-rays, and these were repeated about 4 hours ago. We can see some translation of C2 and C3, and because the patient was complaining of neck pain, then the halo was removed, and he opted for surgical treatment. Where's mine? Okay. So these are the images, right, after surgery. The image on the left shows an occipital C4 construct. There's worse translation of the C2 vertebral body on C3, and there's questionable purchase of the lateral masses of the screws at C3. And then also 2 weeks later, we can see the construct with the image in the center. And then almost 1 year later, we can see with the image on the right, we can see some haloing of the screws in the lateral masses. And there's a severe collapse of the C2, C3 disc.
Yeah.
So he had a new CT scan. With this new scan, we were able to see that the fracture has healed. The disc collapsed at C2, C3. There is more degeneration of the discs at the caudal levels below the construct, and there is haloing of the screws at the lateral masses. So here we can see that the fracture has healed. The coronal view, the trending vertebral junction looks good, and the haloing of the lateral mass screws. So he presented to our clinic with neck pain, bilateral arm pain, numbness, and weakness. His vital signs were stable, a little bit hypertensive. His neurological condition was intact. He had posterior tenderness to palpation diffusely, and some muscle spasms were noted. His incision was well healed, and these are the X-rays we obtained in our clinic. We got flexion extension films, and we can see the severe degeneration of the caudal discs below the construct, the haloing of the lateral mass screws, the severe disc collapse at C2, C3, and the translation of C2 and C3. And there is a trend towards a kyphotic deformity overall in the cervical spine. So this is our case, and actually we ordered some more tests, and we're gonna revise it in the next few weeks. Thank you.
So thanks for sharing this case. Do you mind going back to the initial injury film, the initial CAT scan maybe? So this is an interesting fracture, and if I may put you on the spot, yeah, keep going to the initial CT scan. So yeah, maybe the CT scan, yeah. The CT scan was very helpful. So this is a fracture that has confounded many people for a long time. And the reason for this is that this is not a simple fracture. This is not a regular Hangman's fracture. As we did the AO classification, we're really struggling with these. So we actually put those into a special injury category. The axis, the second neck vertebra, is unique for having very bizarre, unusual fracture patterns that kind of are a combination of a little bit of everything. Like here, there's a lateral mass fracture of the C2 segment that goes into the C1, C2 joint. So this is a very complex injury mechanism reflective of the complex, unique anatomy of the C2 segment. So this is a warning to every clinician that this is not your Joe Blow routine fracture. This is a little bit of a problem fracture. I think it's great that you got a CTA on this patient because there's clearly a high propensity towards a vascular injury. I'm going to pass the microphone on to my partner, Dr. Skuyan, to see what he thinks about the management and going to the occiput. But obviously the C2-3 motion segment here has a significant injury disruption. So if we can steer the camera towards Dr. O.
Yeah, so can we go back one more? There was some plain x-rays. Okay, one forward, sorry. So there's kind of two ways to manage this. I think if you look at the initial injury, it doesn't look that bad on the plain x-rays. But I'm sure, if you look carefully at the MRI and the CT scan, this is actually one of the things that always is concerning is there's more injury to the soft tissue, ligaments, discs. So I think this was managed appropriately. The only thing I've sort of gone on these cases now, I do, I like to go anterior because you can put in, large allografts, you can put an anterior plate on. You don't have to go posteriorly. And I think going to the occiput on this case, I think probably didn't necessarily, fix the alignment. And if you keep going forward, although the fracture healed, I think, I wish we had some upright x-rays, but you can see the alignment is still, he's pitched forward a little bit. There's still anterolisthesis. But, I like going anteriorly. He's a smoker, he's young. It's kind of a big deal to go to the occiput. And to get the occiput C1 and C2 to fuse is still, even with all the great instrumentation and BMP and everything you can throw at it, it's still a big operation. And in my opinion, if you can salvage most of the rotation in the human spine comes between, and if you look at the occipital condyles there and the C1, C2 joints, that's where most of your rotation in your skull and your ability to kind of look left and right comes from. So I think if you can preserve those, I think there's just a lot of downside to going anterior. So that would be my only recommendation is, consider going anterior first and then posterior second.
So Rod, what would you do now?
I probably would go in and take out the hardware in the back and do an ACDF at C2-3 and C3-4.
Mm-hmm.
So in fact, I have a case of my own that we're going to present, I think, in our conference on Friday, where I did this. I did a C2 to T2 it was a patient of mine who had a really kind of benign-looking fracture of C2, and her C2 screws kind of didn't move, and then within 2 weeks, just like your case here, she totally fell apart. And I went in only anterior, and then 3 weeks later, the entire anterior thing fell apart, and then I had to go to C1, and I had to redo the anterior ACDF that I'd done. So, these are tough cases, and I've had it fail anteriorly as well. So,
Yeah, so this particular case, it came to us from an outside hospital, but one reason I was presenting is whether most surgeons feel there's a need to go to the occiput. When I was looking at it, I didn't feel that we needed to go to maybe if you could get it, like you were saying, anterior in, then you could have avoided going to the occiput. But
yeah, I completely agree, Maxwell. This is a great case. Thank you so much for showing this. There are a lot of important messages in there. And for our fellows in the room here, we have, I think, 6 or 7 of our fellows and several of our students here. This is, for me, one of those device problems. Industry has brought up a really big push towards craniocervical fixation. Companies have put a lot of nice little gadgets in there. Nowhere in those x-rays have I seen any real graft in there. So to get these to actually heal is a big deal because there's so much motion, as Rod said, in the craniocervical junction. And to deprive that of the body is a big deal functionally, but it's also a big challenge to get that to heal. So not forgetting the lessons of a quality craniocervical graft like Dr. Benzel and Dr. Bowman have taught us in the older generation is a big deal. And just putting some hardware in there does not solve the problem. This is obviously a very major reconstructive problem with posterior hardware that's pushing the C-spine into malangulation. So revising this is unfortunately necessary, and it's probably taking the posterior hardware out, realigning the neck from the front, as Rod said, and then probably putting a posterior fixation in. I'm actually curious and would love to hear your thoughts. Might you think about not fusing to the occiput this time, just stopping at C1?
yeah, my thoughts were, do like a 540 procedure. First, take out the hardware, and then if there's any fused segments from the back, release that, then come back anterior. So when you take out hardware, try to get screws in C1, possibly C2 and 3, and then come back anterior, put the grafts, and then go back and put a rod. But go back to maybe C1, depending on if you could get good fixation in C2 anteriorly and C3 anteriorly. Maybe stop at C1, not go back to the occiput.
I think that'd be a very meritorious idea, and I think the patient might be very grateful for that. So stopping at C1 hopefully would be possible and should be possible probably. And again, but this is where the posteriorly placed hardware created a mess, and this is probably a very aggressive fixation that was chosen there. Going to the occiput for Hangman's fractures is very, very rarely necessary in isolation. Right, Rod? Did you ever go to the occiput? Here's Dr. Newell also.
Only, if the patient's had their head taken off in a trauma, or if you're doing a tumor dissection, or if you've got a bad pannus or something like that. And I think the strategy here is a good one. So,
just a comment. I was wondering if you would consider using, or any of our colleagues would consider using BMP on the second posterior cervical if you left the occiput out.
Yeah, as discussed earlier, BMP would be an off-label application, but in a healing impaired patient, posteriorly only might be a good idea. Great cases. Maxwell.
Yeah, thanks. Just a quick question to when you do your 540, do you like to stage it or do everything on the same day?
That's a great, insightful question for many reasons. I personally like to do it in the same day if medically feasible. So here I take out the posterior hardware. I'd release the posterior joints as good as possible. I think Dr. Huang was just commenting in the chat room on that. And then we'd come anteriorly. We'd do an ACDF C2 through C5, just doing a multi-segmental release of the disc spaces under a microscope, do multi-level uninstrumented grafts in there. They're probably oversized. And the idea of not instrumenting it would be appealing because that allows them posteriorly to do a lower dosing procedure. And then posteriorly, as mentioned, C1 to whatever, C7 fixation probably. Off-label BMP could be considered. Now, the advantage, obviously, of doing it in one day is you get it over with, you have the best possible alignments. The disadvantage is surgeon fatigue. The patient has to stay intubated overnight. I think that's pretty much mandatory almost to avoid the almost inevitable airway swelling. So a controlled extubation the next day would be very important. I'm not sure what your thoughts are, but I would personally prefer doing that in the same day. What do you think, Maxwell?
Yeah, I usually base it on the duration. You know, I try not to do anything over like 7 or 8 hours. You know, so if I could get everything done within about 6 hours or so, then yeah, same day. But if it's going too long, then I stay. The risk of staging, you're right, is if you get the anterior grafts. So one possibility is do the posterior osteotomy and the anterior on the same day, and then come back the next day or two and put a rod. But then you could lose some of the correction. So that's the downside of staging. So preference to try to do it, but if it's going to be too long, and then yeah, I generally would stage because I don't like putting people really long surgeries. You know, he's a young guy; he might be able to tolerate, but that's the general kind of guiding principle for me.
Yeah, reducing the flips is certainly appealing, and this is again where a team concept comes in. We honestly take about an hour for a flip, and that includes neuromonitoring and everything like that. And we have a very solid team here. So each flip is a strategic investment in time. And I always envied Dr. Harms in Germany, who when I timed him, he was under 30 minutes for flips. I still don't know how he did that, but it was just like a NASCAR thing where everybody's just. We try to emulate that here, but honestly, we're still an hour. I don't know how it is with you.
Yeah. All right. Let me go into the talk. So the learning objectives. Why is this taking so long? Oh, there we go. So basically, we wanted to review the classifications and the mechanisms of the fractures, and to understand the initial stability assessment, radiological features of the fractures that can be managed non-operatively. And now we've kind of talked a little bit about these already. And also we wanted to understand the indications post-surgery and the best surgical treatments, and also discuss the atypical Hangman's fractures, you know, kind of the traditional fracture with a twist to it. So just a brief historical perspective. In 1866, Houghton described a fracture dislocation of the axis in criminals that were executed by hanging. And then in 1908 to 1913, Wood Jones published in the journal Lancet findings of fracture dislocation of the axis in criminals who had been hanged using a knot that was below the chin. And then in 1954 was the first radiographs of a fracture of the posterior arch in a patient sustained in a motor vehicle accident with an appearance that really looked almost exactly like you see in judicial hangings. And then in 1965, Schneider, who was a neurosurgeon, I believe, at the University of Michigan, gave the term the hangman's fracture. So that dates back to 1965. Just a brief overview of the anatomy. So the traditional hangman's is a fracture through the pars interarticularis. That's the area shown in blue. It's usually a bilateral fracture. And then the pedicle is that area shown in green. Sometimes some of the fractures may have extended into the pedicle as well. This is the typical MRI imaging. There is usually a possibility of a C2-3 disc injury. There is posterior ligamentous injury. There's prevertebral soft tissue swelling, and there's various amounts of posterior either hematoma or disc, sometimes behind the disc. In terms of the classifications, there are basically four main classifications, and this slide shows the timelines they've been around. So the Effendi, which is based on a lateral radiograph, was proposed in 1981, and Francis, I believe in the same journal, proposed it also in 1981. And then Levine was 1985, and the most recent classification that is popularly used around the world is the Justin classification, and that one does incorporate the MRI as well as the anterior longitudinal ligament So that, I think, has been a good addition to the classification system. So these figures here from the paper outlined below here shows the different groups. So the Effendi is basically no displacement, no injury to the disc. It's just a fracture through the pars. And then there is the Effendi Levine 2A, which shows a fracture of the pars, the disc, and the anterior ligament. And the 2A, which we talked about already, is really a significant hyperangulation, usually with the intact ALL, but it's a highly kyphosis. And then the Levine 3 is when you have locking of the posterior facets, a very highly unstable injury. And so if you look at the mechanisms, the type 1 is generally from extension with some axial loading. The type 2 is also axial loading with extension with some rebound flexion. And the type 2A is, as Dr. Chapman mentioned before, that's a flexion distraction injury, highly unstable. Traction is essentially relatively contraindicated. In fact, this figure, which is from Greenberg, the Handbook of Neurosurgery, specifically says do not use traction. And then in the type 3 is also a flexion injury with some compression, and also traction is considered to be dangerous in the type 3s. The type 3s is the one that has the bilateral locking of the facets. And the Francis classification is a little bit different. The Francis is based as a quantitative classification. Less than 11 degrees is the type 1, and the type 2 is greater than 11 degrees of angulation with displacement less or greater than 3.5 millimeters. There's also a Francis 5, which is when there's any disc disruption. And so this is how the Francis measures the displacements. You know, the D would be less or greater than 3.5 millimeters, and that puts it into the Francis 1 or 2 categories. The Justin classification, as I mentioned, was proposed in 1999, and in the type 1, there is an intact ALL. The type 2 has an intact ALL with a ruptured disc, and then the type 3, the ALL is ruptured, and the type 4, you have the locking of the facets. And in the recommendation, they proposed these treatments listed here as plausible for the different types. This algorithm is proposed by the spine section of the German Orthopedic Society, published in Global Spine Journal in 2018. And it shows how you can use the CT and the MRI to classify the fractures. And so with a dislocation that is less than 3 millimeters, it puts you on the left side. If the MRI is intact, then it's 11-1, Justin 1. If the MRI ALL is intact, but you have a displacement greater than 2 millimeters, greater than or equal to 2, and angulation greater than 11, if the ALL is intact, then it puts you in the 11-2A Justin 2 category. And if the ALL is not intact, then it's 11-2 Justin 3. And then with the facet lock-in, that puts you into the Levine 3 or Justin 4 category. This slide illustrates the classification of the atypical hangman. So the atypical hangmans are basically, you have a fracture involving the body of C2. And so there are 2 classifications that have been proposed. One is by Al Mahfoud in Global Spine Journal in 2016, and the other is by Lee et al. In Medicine in 2017. In both cases, the C2 body is fractured, usually in the posterior aspects of the body. So in the Lee classification, A1 would be a fracture of the body with a contralateral pars fracture, and the A2 is with a contralateral laminar fracture, and then you have bilateral oblique fractures as a B1, and an oblique fracture, one which is oblique and the other vertical, is a B2. In the Alfardi, the type 1 is basically a coronal oriented fracture through the posterior C2 body. And then depending on whether the oblique fracture is with a contralateral pars or a laminar fracture, is a 2A or a 2B. So this slide shows the first classification, and you can see that type 1, you have a fracture through the posterior C2 body, and then in the 2A and 2B, you have the oblique fractures. I think you can see it very well here. Type A1 fracture on this left side image, upper left, you see the posterior fracture in the body, and then the A2, you have the oblique fractures through the body. And so what they have shown is that actually the majority of Hangman's fractures are these types. About 50 or 60% of them are atypical, and they tend to be associated with more neurological deficits. And so it's important to recognize these fractures. In terms of the recommended management of these fractures, for type 1, they're typically stable, and so you can try a halo or a collar. And then the type 2, we talked about that, that's the halo or surgery, and the types 3 is almost always surgery. This slide shows the surgical options. So you can do a C2-3A CDF, you can do a C1 to 3 fusion, you can do a C2 to 3. Remember, the instability is between C2 and C3. And so whatever you do, you need to go across from C2 to C3. And you can also put a screw in C1, C2, and C3. And finally, there is a subset of fractures that you can treat with this lag screw called a Judet screw. It's a lag screw that pulls the fragments together. Obviously, if you're gonna do that, you have to have an intact disc and an intact ALL in order to use the lag screw technique. So this slide kind of shows you the different algorithms in terms of picking the surgical options. Way on the right is the type 3, you have severe kyphosis. You can do a posterior C1 to 3 or C2 to 3. If you can get reduction, then you can stop there, but often you may need to do a combined anterior posterior. At the very bottom in the right lower corner is this thing called Liberation C1-2. This is a strategy where you do a C1 to 3 procedure, and then you do a C2-3A CDF, and then you go back and remove your C1 screw in order to get a good stabilization without significant disruption of the rotation, which is primarily at the C1-2 level. So based on all of this, let me show a couple of more cases, and we can then see what pearls we learn from these. So this next case is a 69-year-old who had an MVA and was neurologically intact with disc fracture here. You can see on the MRI, there is an injury of the disc and ALL with some angulation. You can see also that the fracture is going through the posterior body in an oblique fashion. So this is sort of like an atypical fracture. There is a little bit of listhesis and angulation there. So in terms of classification, we know the ALL is torn, the disc is injured, it's a Levin-2, Justin 3 classification. This patient underwent an ACDF, but a week later, there was more kyphosis. and then underwent a posterior procedure. And you can see that a year later, there's a broken screw there, and this image is 1 year later. This is one of my partner's cases. Let me show another case. This one is a 56-year-old MVA, neurologically intact. Here's the films. You can see that this is the type 1 atypical fracture that I talked about. You see the fracture in the posterior C2 body. And so it's atypical. It's very important to recognize these atypical fractures. Here is the MRI scan. It shows the ALL is injured, the disc is ruptured. Once again, it's a Levin 2, Justin 3 typical fracture. He underwent an ACDF. Unfortunately, I couldn't find the immediate post-op film. The film on the left is the intraoperative film, but the film on the right is the CT scan of the patient. That is 1 month post-op, showing a failure of the construct, 1 month post-op. So the important thing is, why did it fail? What was, and I think part of the problem is it's a Levin 2 Justin 3 and a typical fracture. And, he ended up requiring a additional posterior instrumentation. When I looked at the literature, there is a lot of reports saying anterior is good enough. In this particular study, you can see that they had a variety of Levin 2s, 2As, and 3s, and they claimed that they had good, excellent results in almost 30 patients with an ACDF alone. So there are reports that you can treat even very unstable fractures with ACDF alone. We published a paper about, I think this was last year, showing that in atypical fractures, three of the complications we had was in atypical fractures when they were treated with C2-3 alone. I'll be interested to see what you think, Jens and Rod, whether you've seen this in your own practice or you have any pearls related to that. So my inclination with atypical fractures is, if I do a ACDF, I'm really kind of low threshold to maybe adding a posterior approach or monitoring them very, very closely. So just to illustrate the C1 liberation screw technique, this is a paper that was published in the Global Spine Journal in 2015. You can see it's a Levin 3 fracture. There is dislocation, there is facet dislocation, severe angulation. So they did a posterior C1 to 3, and then they supplemented it with a C2-3 ACDF, and then subsequently they went and removed the C1 screw. This has not really been my practice, but I'm showing it here to see if what people think of this technique. The advantage of it is it helps preserve some of the motion of the neck. They add the C2-3 in order to be able to release the C1 later. I thought it was an interesting technique. They also say that they added the C2-3 because after the C1 to 3, they felt that there was a need for additional stability. In reviewing the guidelines, and this is a couple of more slides, and then we get to the end. In removing the CNS neurosurgery guidelines, the guidelines are not very specific in directing, like standard of care. So there is really no standard of care. These are level 3 recommendations. They basically say surgery is indicated for highly unstable fractures, but it doesn't really guide any further than that. This is a paper that was published by Dr. Vaccaro's group. It's an excellent systematic review. And first of all, it's a very interesting, when you look at the table 2 here, it shows that there was no difference between a rigid collar and a halo. And in fact, if you look at the treatment failures, 5 of the halos failed. 5 of the 86 in the halo failed, as opposed to 0 in the collar. So this paper would tend to support the use of a hard collar instead of a halo in patients that both have equal equipoise, that perhaps a rigid collar would do just as well. In the table 3, they compared the ACDF and the posterior approach. And they found, if you look at the p-values on the 4th row there is no difference in the surgical outcomes, in the deaths or complications between the posterior or the anterior approach. So their conclusion basically was that they concluded basically that while the surgical treatment leads to an increase in the fusion, there's really no difference. Neither the anterior or the posterior approach seems to be superior. This paper then shows the group of patients that underwent anterior and posterior surgery. And they showed that for various fractures type 2 and type 3, doing an anterior posterior approach resulted in really excellent outcomes. And so I think that is a question that is not really been totally answered well in the literature, is should we be doing more anterior and posterior approaches for these some of these highly unstable fractures, given some of the failures that we presented today? I think that's something to think about. At the very least, I think we need to gather more data on the use of an anterior posterior for some of these highly unstable fractures. So in conclusion, I would say that for the Levine 1, Justin 1, generally a conservative management based on Vaccaro's paper, perhaps with a rigid collar. With the Levine 2, Justin 2, an ACDF or posterior C2-3, I would consider combined if there's a typical fracture, or if the alignment after your ACDF or posterior approach is not optimal, and same recommendations for the Levine 2, Justin 3 fracture. That's the fracture where the ALL is torn, and I have a low threshold if the alignment is really not optimal at all. If I don't get the adequate amount of reduction, I think it's probably best to supplement with anterior or posterior if you do the anterior first. And certainly with the Justin 4, I'm really kind of interested in hearing comments about doing the anterior posterior and then maybe removing the C1 screw later. I've never done that myself, but that seems a pretty attractive option. So I think I'll stop there, and maybe if there is a few questions in the last 4 minutes or so, that would be good. Thank you.
Maxwell, this was outstanding. Thank you for taking on this topic. As you correctly point out, there's a lot of equipoise in terms of treatment recommendations. You've provided a lot of structure and great and welcome oversight. As an AO member, I obviously would be running amiss of my duty to inform you that we have a very nice upper cervical spine classification system also. Hangman's fractures would be mainly in the category 3. And they do differentiate the pure bony injuries from the ligamentous injuries. So hopefully the next even better round of your talk will include that effort, which is a global effort to try to have more consistency, but great job. So the question of taking screws out for a C1, using C1 as a temporary fixation is an interesting one. That's again where we get into the cone of efficiency kind of, it becomes pretty difficult to justify that. I think the devil's in the detail. And I think that one of the key first classifications you point out that I've always found very appealing, that's been overlooked, is that of Francis. His identification of translation and angulation as being negative prognostic factors still remains unsurpassed, I think. So if you see something that is really displaced in both planes, then you probably have to think about a more invasive surgery with an inclusion of C1. And whilst it's a sad fact for the patient, it's not the end of the world if you have this kind of a significant displacement. The higher grade Yosten 3 type injuries would obviously fall into that. Otherwise, the workhorse has been the anterior procedure, and you correctly point out that this is very subject to failure if technical details are not listened to, like bicortical screw fixation, and as you did in your beautiful case, contouring the plate down so it does not sit off the front of C2, but hugs the front cortex closely so that there's no dysphagia from mechanical impingement. Those are some first thoughts. I don't know, Rod, do you want to add something to that?
Yeah, Maxwell, that was terrific. I think one other thing I look at, and I'm sure you guys too, is mechanism of the injury. So, if it's an MVA versus, a low impact, I think that gets overlooked. And I don't know of, I tend to collar, the type 1 and type 2. And then when you start to get anterior displacement and the disc is disrupted, I think we all will operate on those because we know they're going to fail. But I just, I sort of, halos for our practice and our population, I just don't do anymore. And I think it's for us, it's, when I have a patient with this type of injury, it's mechanism of injury, and then their overall kind of medical condition. And then the third thing is, either operate early or put them in a collar. We really haven't been haloing that much.
How about you, Maxwell? Do you still use halos?
Yeah, we still use some. I would say we probably do half and half.
Great.
It's because it's attending dependent. And so some attendings like halos, some like collars.
I mean, the halo has just really kind of come a full circle, and it's become so unpopular nowadays. It's very interesting because when I was at Harborview, we did like 50 a year, and now I literally do maybe 1 a year. So it's and patients really don't like them very well, but it's a workable modality. And again, for displaced Hangman's fractures, it was a very serviceable treatment entity. Well, it's 8 o'clock. It's a little bit past 8 o'clock. Maxwell, thank you and your group.
Yeah, thank you. Thank you so much. Appreciate it.
Great presentations. Thank you.
Thanks.
Thanks for watching. Hit the subscribe button for more medical content.